So my name is Kathy Spencer. I'm a pharmacist, and I work at Sullivan University College of Pharmacy. I teach as an assistant professor there, but as part of our job, we have clinical practice sites where I go and practice clinical pharmacy. And my practice site is right down the street at the 550 Clinic, which is our Ryan White-funded HIV clinic here in Louisville. So we see mostly HIV positive patients. We don't do a ton of PrEP in our facility. A lot of what we do are referrals out to primary care offices, Dr. Krieger's office, in order to start PrEP. But very often we have patients coming in asking, patients living with HIV and their partners are negative, and so they want PrEP, and they're asking, I'm really interested in this, but I'm really nervous. What's the cost? What is it going to cost me? And so very frequently I'm talking with patients and their partners about how to afford PrEP, and so that brings us to the conversation today, which is mostly going to be geared on access in terms of medication cost access. We will talk a little bit adherence at the end, depending on the time. I don't know if we'll have time to get to too much of it. For the most part, we're going to focus very much on making sure that patients can afford PrEP. So before we get going too far, though, I am kind of curious as to who we have with us today. So let's see. If you are, I guess instead of show of hands, let's just do applause, because that sounds like fun. So we'll do applause. So just give a little clap if you are a primary care doctor. Oh, okay, great. All right, what if you're another healthcare professional? Go ahead and give a little clap. All right, very good. Public health? All right, I've barely gotten started. Thanks, guys. Okay, just kidding. But anyway, anyone else that I'm leaving out? Yeah, and what do you do?
I'm a clinical librarian.
Clinical librarian. Okay, well, great to have you with us today. I'm glad that you're interested in PrEP. And so we'll go ahead and jump right in. Unfortunately, no one's paying me to do this. Maybe next time. So PrEP in Kentucky, honestly, we've come a long way in the last year or two from what I've seen. We see a lot of patients coming into the clinic and partners who are on PrEP, and that's awesome to see. But for the most part, in Kentucky, we have a lot of roadblocks. And so if you're wanting to start PrEP in Kentucky, it's going to be a rough road ahead. So as far as affording PrEP, unfortunately, in the state of Kentucky, we don't have a ton of resources in terms of ADAP resources. So every state has its own ADAP program, and that's called the AIDS Drug Assistance Program. We use this very frequently in Kentucky for patients infected with HIV. So it's called KDAP here in Kentucky. We like to run our words together, so Kentucky ADAP, KDAP, right? So KDAP covers our patients who are living with HIV. But unfortunately in Kentucky, we have no resources for patients who are HIV negative in terms of using that ADAP funding to cover PrEP. So we have to rely on our other resources. So the objectives today, there's only two. We're going to focus mostly on the first one, and that's going to be able to navigate those resources that we do have available to us in order to afford PrEP, and then also to identify any tools that may help patients to become more adherent. So we'll focus mostly on the first objective today. So in order to break it down, we need to think about patients who have insurance, patients who don't have insurance. And keep in mind, if you don't take care of patients, that's okay. You could apply this to your own situation as well. So if you have insurance or don't have insurance, so whatever your situation brings you to. But let's talk about first people who have insurance. So in order to do this, I wanted you to go ahead and get into some small groups. I'm going to ask Jacob to come help me because I have a handout to give you all. Okay, so we have a scenario up on the screen, and I want you all to read it. And I'm not going to give you a ton of direction for right now. I want you to just read the scenario. And, oh, sorry, I didn't mean to pass you up there. There you go. Let's go through the scenario, and then I want you to work in your small groups for just a minute using this flow chart that I'm giving you. I just want to see how well you can, it's pretty easy to use, so I want to see how well you can navigate it before we go through it together. Thank you. So scenario one, this is a person with commercial insurance, so they have private insurance with a high copay. So this is a 28-year-old male. He's wanting to start PrEP. The indication doesn't matter right now because we're focusing on the cost. So this patient has Express Scripts for their prescription insurance, but they have a $1,500 deductible. And so up until they reach that deductible, they're responsible for 100% of the medication costs. But then after that, the copay becomes only $30 a month. And this patient has the first prescription sent to the pharmacy, and the cost is $1,359.73. And so he calls your office and says, I can't afford that. So that's your scenario. So go ahead and work in your small groups to figure out what options may be available for this patient. Anybody come up with anything? Any ideas? Yeah.
That left word column where it says yes, they have insurance, and then we don't know what their annual income is, and so, but it looks like they may qualify for the Gilead copay card.
Okay, awesome. So as of right now, what we're hearing is a copay card, and I think that that's a great way to start. So I'm going to go through this up here on this slide. So this is a flow chart that I gave you, and if you look over to the left, down the yes, because this patient does have insurance. We were told that he has Express Scripts insurance. So we're going to look at that yes side of the column. And these numbers, 1, 2, 3, there's really 3 options, kind of 3. We'll get to that in a minute. But there are 3 options for patients who have insurance. And the first one that you're always going to go to is going to be the copay card. That's probably the best. In order to do this, what I would do honestly is go from left to right. So you start with 1. If 1 is either not enough money or is not possible for some reason, then you're going to go to 2, then you're going to go to 3. So for this patient, we'll start with 1, and that's going to be the copay card. Only patients who have insurance can use the copay card. And unfortunately, it is limited in a sense that if you have any type of federally funded insurance, such as Medicaid or Medicare, you're unable to use it. And so in this case, that would be a situation where you would jump to step 2 or step 3. There's a $3,600 maximum limit per year on the card. And then the other thing that is, the other nice thing about this, in addition to covering $3,600 in medication, is that there's no income restrictions. So regardless of how much the patient makes, they're able to use the copay card. So that's really great. The information, since these slides will be uploaded, there's a link and then the phone number as far as you want to help patients get registered for it. The next one that we'll talk about, and this will come up in a little while, but number 2 on that flow chart is going to be the PAN, or the Patient Access Network Foundation. I call it PAN for short. And so the PAN is also only for patients with insurance. However, they can still use it even if they have Medicare or Medicaid. So that becomes a nice option for patients who can't use a copay card. The major problem with this, as well as the PAF, which we'll talk about next, option 3, is that these funds open and close depending on available funds. So if you were to go to try to register a patient for a PAN right now, they would tell you that they're out of funds. So you can't use it. So, and that was as of whatever, sometime this past week when I tried to do it in preparation for this talk. So they're out of funds. They did recently change it to where prior to, I think it was sometime in the beginning of this year, it used to only be available for treatment. You can now use it for prevention as well, for PrEP, but as of right now, it's not an option. It is based on the federal poverty limit, so they have to be less than 500% of the federal poverty limit, but it has increased its maximum to $7,500 per year. So this is an option maybe in the future, just not currently. The one that is available right now is the Patient Advocate Foundation, or PAF, as I'll call it for short. And again, similar to the PAN, it's very, very similar actually, where they have to have insurance, but it doesn't matter, they can have Medicare or Medicaid. There is an income restriction. It's a little bit different. With this one, you have to be less than the 400% of the federal poverty limit. But it does, and still has the same $7,500 maximum per calendar year. And just like with the PAN, this organization also opens or closes its funds depending on, or opens or closes depending on the funds that it has available to it. But currently, you can sign people up for PAF. So there are funds available as of right now. So these are 3 options for patients with insurance. So that leads us to talk about, so let's go back to our patient case. So this is a 78-year-old male wanting to start PrEP. He has insurance, so we're going to look over here on this yes column, and we're going to first start with a copay card. And so when you sign someone up for the copay card, it's very easy. You go to the Gilead website, put in just a little bit of information. I signed myself up for one. What did you say?
45 seconds.
45 seconds. I mean, it was like so fast. And it spits out This, I covered up my ID number so none of y'all try to use it, you know. But here's my copay card, right? And so it gives you all this information right here, the RX bin number, the PCN, the group number. This is all stuff that the pharmacy is going to need in order to bill this copay card. So the way that it works is the pharmacist would go ahead and bill your primary insurance first. Whatever that copay is or whatever it's telling you you are responsible for, the card picks up the rest, up to $3,600 a year. So if your copay was like if, for example, he were to have to use a 90-day supply per his insurance and his copay was $3,000, it would cover it all at that one time. So it's no limit in terms of if you use all of that $3,600 in 1 month, or if you use it within a year, you have it available to you. You can use it however you choose, just like it's your own money. So, but that's the information. It will come up on the screen. The patient will immediately have it, and it'll also mail them a card in 7 to 10 business days that they can have and keep in their wallet. So for this patient, you know, the first fill is going to be expensive. It's going to tell him that he has to pay this $1,300-ish, but then the cost of the copay card should cover all of that. So the cost of the patient at the first fill is going to be $0. The next time he goes to fill, it's probably going to tell him about the same amount of money, because he meets his deductible once he reaches $1,500. So the second fill will likely still be cash price. And so then the copay card's still going to cover the remainder of that, and the cost of the patient is again $0. So then after that, he's met his deductible, right? So remaining on the deductible $0, but we said that his copay is going to be $30 per month after that. Well, guess what? There are still funds remaining on that card, right? So if you have to do a little math, and I know it's early and it's Saturday, so I won't make you do it, right? But so we've got $3,600 available to us. If we subtract these copays that covered before, we still have $880 left remaining to help cover those $30 per month copays. And so check, this patient is fully covered. They shouldn't have to pay for PrEP at all. Yes?
We were just talking about something that I encountered in my practice that's interesting, which is that some insurances have these specialty pharmacies.
Oh my gosh, yes.
If the prescription accidentally goes to the specialty pharmacy that's covered in the non-specialty pharmacy, cha-ching on the specialty pharmacy, and then lower copay on the non-specialty. So it's worth calling to see where the prescriptions landed in that duality.
Absolutely. So,
Huge difference.
yeah. Did everyone
tenfold.
hear that as far as specialty versus non-specialty pharmacy?
So, New York City
Give you my
Insurance
microphone.
Express Scripts is GHI. Sorry, is GHI, which has Express Scripts, but they have a subspecialty pharmacy called a Credo. If the doctor sends a prescription to a Credo, it's a $400 copay. If they send the same prescription to Express Scripts, it's $40 every 2 months. With nothing. They don't accept the copay card at Express Scripts, interestingly, in that situation. But it ends up that where you send it matters.
Yeah, it does. And that's why, you know, it's always good to, I think it's very good to get the patient involved, I mean, in their own health. And it's good at practice, I think, all the time. We always advocate, I can't get this thing back on myself now. Hold on 1 second. All right. It's always a good idea to get the patient involved in their own health and be an advocate for their own health care. And I think that this is a great situation where, you know, you want to help the patient, but you don't necessarily want to do every step of the way for them. So you can tell them, go ahead and call your insurance company and see, you know, where's the best place to send it. And if they're unable to do that, then of course you can do it. Or have, you know, the pharmacist help you out with that. I know I'm calling Mallory all the time. She works at our Walgreens specialty pharmacy on 4th Street downtown. And yeah, I think that we really need to be utilizing the pharmacists in the community in order to help with some of this medication assistance. But specialty pharmacy is definitely a huge, you know, thought with PrEP. There's a lot of limitations in terms of certain insurance companies need it to be through specialty. Some of them don't. And it's very individualized for each patient. So this is a great point. All right, so let's go ahead and work through the next scenario. You guys can take just a couple minutes again in your groups. So in this situation, the patient is a 65-year-old female. She started PrEP 3 months ago. And originally, the copay was only $20 per month, and so she was being able to afford it. She was just paying out of pocket for that $20. However, she's now in what's called the donut hole. Is anyone not familiar with the donut hole? Okay, we'll go ahead and talk through it, sure. So the donut hole is supposedly going to be reducing, and I don't know how that'll change. We will just won't not go there. But anyway, so Medicare. With Medicare, you essentially are riding. Think of it like a donut, okay? Like you're walking along a donut. So at first you're walking along the donut and you're being covered, and then all of a sudden you like fall into what's called the donut hole, and you sink down into this donut hole, and for however long you have a certain amount of money that then you're responsible for paying, where they pay less basically on your medications. And so patients will say they're in the donut hole, which means that they're being charged more for their prescriptions than they were in the beginning of the year. And so when patients fall into this donut hole depends on how much they utilize their health care. So if they are, in the beginning, if you spend a ton of money in January and February, you might fall into that donut hole in March, versus some patients might not fall into the donut hole until August or September. And they have to get through this donut hole, pay however much money the insurance tells us to make, and then they come out of the donut hole and it starts covering it more. It's kind of this crazy concept that we have, but that's where this patient is. So she's now in the donut hole, and her prescription cost has now gone up to $1,359. I just really like that amount. So anyway, she works part-time, her husband's on disability, and their combined income together is $45,000. So go ahead and work in your small groups, see if you can come up with any solutions for this patient. So who came up with a good solution for this patient? I know you guys said that you maybe came up with one, so what did you all find as a solution for this patient potentially?
So for this patient, since they are a Medicare patient, they probably will not be able to use a copay card. So I think either the PAN or the PAF, options 2 or 3 would be good. Considering right now I think PAN is closed, we decided to go with the PAF.
Okay, great. Well, that's exactly what I was going to say, so you guys hit the nail right on the head. So this patient, again, has insurance, however, she has Medicare. So this first copay card is not going to be an option for her since she has a Medicare plan. So the next thing we need to look at, since considering that both of the next 2 options are based on the income or percentage income of the federal poverty limit, we need to look at what is her income. So this is not something that I have memorized off the top of my head, so I just Google it anytime. You can just Google federal poverty limit income 2016. They come out with a new one every year. But it's based on the family size as well as the amount of income that you make. So on the left-hand side, we have the family size. So I think the patient said she was living with her husband. So it's just 2. There's no mention of kids, so I'm assuming she doesn't have any. So for the purposes of right now, we're going to assume that she has a family size of 2. And so this is the poverty level, and then it breaks it down into the percentage of the federal poverty limit. So for the PAN, they cover up to 500% of the federal poverty limit. But as Danny mentioned, currently that is not enrolling new patients. So we have to go to option 3, which is the PAF for PAF. And the cutoff for that one is going to be 400% of the federal poverty limit. So since she makes $45,000 a year, she's well below this number. And so she would, in fact, be eligible for the PAF. So this one's not going to be an option since it's not enrolling patients, but this third option would absolutely be wonderful for this patient. So as far as breaking it down for her, she gets $7,500 per year coverage for medication costs through the PAF. In this case, she only needs, for right now, for this month at least, and we don't know how long this donut hole is going to last her right now, but she only needs $1,300, ish dollars per month. And so this is going to cover her, that PAF is going to give her prescription coverage for at least 5 months. And so most people's donut hole doesn't last for a full 5 months. So that should be well enough money to help cover her. So check again. So these are going to be the 2, these 3 options are great for patients who have insurance. But now let's move over to the other side. Yeah, go ahead.
I have a couple quick questions and a comment. My question is, on these last 2, do they give you the whole $7,500 or do you have to apply every month?
Great question. So the question for those watching the podcast is, for the last 2, the PAN and the PAF, do they give you the full $7,500 per year? Do you have to apply every month? You enroll one time, and that basically gives you that full $7,500. from there on out. So you just enroll the one time. If you run out of it, that's when you have to reapply, or every year, annually. So either if you run out of money, you can try to reapply. It's probably not going to let you, although, I don't know. We did have, prior to them raising the limit, I have been successful with re-enrolling a patient within the same year, and they approved it. So I'm not sure about that. But for based on the guidelines, it says just per year. So they can reapply at that next year. So they don't have to reapply every month. And they can use it however, same as the copay card. They get the amount of money, and it's not saying like you have to use $750 a month. You can use however much that you need in the very first month.
And then my comment is just, these two options are based on taxable income, and your case had the husband getting disability benefits. We don't know how much of that was her part-time work, but
Sure.
disability benefits often at that level probably aren't taxable. So
So
even though her case that doesn't matter, someone else might be over that 400% if you just looked at it that way, but you'd have to go back to the actual tax form and make sure, because his disability wouldn't be taxable possibly, and then they would still qualify even though it looks like they're over, just asking them what their yearly income is.
Yeah, absolutely. I think that's a great point. And as you're signing the patients up, or as they're signing themselves up for these programs, they ask you about any income, whether it be income. They ask you about taxable income, and they ask you about income coming from any sources. So even child support, disability, they ask you to put all of that down. And so that's part of the application, but I think that's great to point out. Another great question we had from this group over here is, can you use more than one? And yet the answer to that is yes. If they qualify for both, then you can use both. So we've had a patient before who used the copay card, but believe it or not, that $3,600 copay card was not enough to help this patient. In that situation, he was required to fill a 90-day supply through a specialty pharmacy. And he had this ginormous copay. I can't remember what it is. It was over $4,000. And we used the entire copay card, exhausted all of those funds, and then moved in. And that time, PAN was available. And so we were able to sign him up for PAN, and PAN covered the rest of the cost. And then at that point, he had reached his deductible, fortunately, and he didn't even need any assistance. So that was really great. So yes, you can use more than one. You can combine them. Great questions, guys. Anything else before we move on to no insurance, the other side of the chart? No. Okay. Oh, yeah, go ahead.
It says that the pharmacies can bill PAN directly. How does it work for PAP? Does that get billed there directly? Or
Yes, you can bill PAF directly as well. They give you the same, and I'm going to refer to Mallory really quick. So Mallory, they give you the same BIN number and all of that also in order to put it in. The same information that kind of looks like the copay card. Is that correct? All the same. Okay. Yeah. All right, great. So let's move on to no insurance. So patients with no insurance. We're going to go ahead and work on this case. So he's a 20-year-old male. He has no insurance. He lives on his own, and he works at a retail clothing store. He makes $21,400 per year. He's wanting to start PrEP, but he's concerned about the cost. So go ahead and work in your small groups and see what options might be available for him based on the flow chart. All right, so on this chart, if you go to the no column, what you're going to see is that I didn't think enough in advance about what date it would be when I gave this presentation. And that's the take-home point, is prepare. So let's pretend that it's not in this column, okay? That it is not November 12th or whatever. Is it November 12th? Is that correct? Okay. Let's pretend that it's not November 12th. So really, if it is today, maybe the best solution is to sign him up for insurance, because while the insurance may not cover PrEP and it's going to require a lot of hurdles, but it's going to put him on the other side of that chart. None of our medication access programs help pay for labs or office visits or anything else. Yeah.
If he's not had insurance, the question I had to go over is he didn't have insurance, so he's going to be penalized when he does apply for insurance.
Mm-hmm.
So it's to keep that in mind, and it's not $35 anymore, it's like $100 and something more.
Yeah.
So that even if this was easy,
Right.
he's still gonna be penalized for not having.
That's a great, and I don't know if you all heard that over on the other side of the room or for the podcast. So it's important to think about too, if he goes to enroll for insurance, he's going to be penalized for having not had insurance. So there's always going to be costs there. Uh-huh.
Just want to bring up the point that at the end of December, Kentucky loses its expanded Medicaid waiver. And so there are going to be a lot of people that are not going to have access to the Medicaid program. It may behoove you guys to think about them getting their STD surveillance at the specialty clinic. That's why I put the handouts out here. The labs can be done cost effectively at specialty clinic, and then within the week taken to the primary care doctor. They would still have to pay their office visits, but maybe we could help them out that way.
Yeah, I think that's a great, that would be a great solution. A little bit more, inconvenient for the patient for having to go to multiple places, but in the end of the day, they get it done, and that's what matters. So let's go ahead and move on to, let's go this direction. So what I really want to educate you all about is MAP, so I'm just going to jump to the point. So Gilead has this medication assistance program called MAP, and this is specifically for patients who are have an income less than $58,850 per year. So that would certainly include our patient, and so he's going to qualify for MAP if he chooses to go this route. And so this is for patients who do not have insurance and are less than 500% of the federal poverty limit. And the website and everything is there for you. In order to enroll a patient, my understanding is that it takes about 2 to 4 days to get a response. That was the average time I called this past week to ask how long it would take to get a response. They told me usually within 2, sometimes up to 4 days. So that would be the only thing, is that slight delay, but certainly worth it because it covers the medication cost in full. And then you don't have to worry about doing any of those other things. So the downside to this, that it does not cover, as with all limitations of all of our PrEP access programs in Kentucky, is that there's no coverage for any type of laboratory visits, no coverage for office visits. So all of that may potentially have to come out of pocket for the patients, depending on whether or not they have insurance, and may be an additional cost for the patients. The availability of funds is not guaranteed, so like we said with PAN and PAF, those organizations open and close depending on the availability of funds. As far as treating, we're talking about costs, so I think it's good to talk about the cost of what it takes to treat HIV. The estimated lifetime cost to treat an HIV infection is over $300,000. In order to avoid one HIV infection, we save, this is cost savings, $229,800. So there's obviously a difference for those of you in public health. You guys are probably all into the cost savings versus cost effectiveness, and there's, you could argue that it's extremely cost effective for patients who are very high risk of infection. For those not as much if they're not at high risk, but either way, it's cost savings, certainly, and it does cost a lot to treat a patient once they have HIV, and that's just, financial costs. That doesn't also take into account all of the other costs to the patient, such as the stigma that they endure when they find out that they have HIV, the travel time, the time off work to come to office visits. So there's all kinds of costs that aren't factored into this number. So I'm going to be really brief and just run through this very quickly. Yeah? The question is, have I found that the Gilead program runs out of money? No. Gilead has a lot of money. Yeah. No, I hear you. No, it's good to think about because the other programs do. They definitely run out of money. Gilead, they're doing very well. Okay. So. Improving adherence. So adherence to PrEP is important. We see that in all the trials. So this is a chart that I borrowed from Danny. So thanks for that, Danny. So the efficacy is over here on the y-axis, and on the x-axis we have the percentage of participants that actually had detectable levels of drug in their bloodstream. So the more, and so if they have a high level of, if they have detectable drug in their bloodstream, that would say that they're taking the drug, right? So as you can see, through in all of these trials, so all of these little colorful dots are different clinical trials that we have for PrEP, and the efficacy for PrEP certainly goes up the more that patients are adherent. So this is a consistent, every PrEP trial that you read, we're going to talk about adherence, And the percentage adherence is equivalent, is correlated to the, the percentage of effectiveness. And so adherence to PrEP is important. So we do have several strategies for improving adherence. As a pharmacist, a lot of what I do over in the 550 clinic is adherence counseling. We talk about adherence at every single patient visit. And so you have to be creative with, helping patients. A lot of motivational interviewing, as Dr. Coker said, as far as learning how to really incorporate PrEP into their lifestyle. And one thing that I like to do before the patient even leaves the visit, and it just takes a minute, it really just takes a minute, but you ask them, what time of day are you going to take this medicine? So it has to be taken the same time every day. You need to take it every day. So what works the best for you? And so if they walk out of the office having a plan, I find that is very helpful. They're like, because they'll say, yeah, I'll take it every day. But then they walk out and they get busy with whatever else they're doing in their life, and it starts varying times, and then they're missing days. And so if, they're leaving with a plan of, I'm going to take it every morning, I'm going to wake up, I'm going to fix my coffee, I'm going to take my medication 8 o'clock every day. That seems to work well. So timing it with things that they already do in their life, that's one thing to think about. Also, pill boxes, those are always helpful. And what I wanted to talk about today are some phone apps. A lot of our patients coming in, not all patients coming in, but a lot of the ones that we're seeing are younger patients who use their cell phones a lot. And so they have apps for everything. I have an app that tells me everything that I do in my life for the most part. If I lost my phone, I would just probably, just walk around. Like, where do I go? Because I don't know. My calendar tells me where to go, So I think that apps are important to think about, and there's a lot of free apps. This one I like. It's called RX Mind Me. I don't mind if you get your phone out and you start downloading them. That's totally cool with me. That's no problem. I won't be offended. Get your phone out. Go ahead and do it. So RX Mind Me, this one is free. All of these are free to patients. This one is kind of cool because this is all it tells you. It says you have prescriptions to take. It doesn't tell you what you're taking. So it's not like, hey, take your PrEP, in case the patients, have their phone laying out and someone sees it. So it just says you have prescriptions to take. You click that little view, you go in, you check a box, yes, I took it. And so they can look back and they can track their adherence that way. MediSafe is really neat. It shows you, it looks more like a pill box, and you click that you take it. But the cool thing about MediSafe is that you can set up a buddy system. So you can have this buddy where, say, I'm on PrEP and you're on PrEP, and I forget to take mine for several days. It texts you and tells you. And it's like, hey, your friend's not doing what they're supposed to do. And so then usually I would defriend him. And no, I'm just kidding. Then we'd stop talking, This ruins relationships. But maybe you should, no, I'm kidding. Maybe, probably, hopefully, if you're doing it, you have your buddy, and it's strengthening that adherence. So that's really good. And then we have RX Mind Me. This is the CDC's app. It's kind of neat because it shows it's only for HIV and for PrEP. So all the drugs are listed there. So for that reason, it's pretty cool. But it's kind of stinks in the same breath because when it gives you that alert that it's time to take your medication, it says, take Truvada for PrEP. And I don't want that on my phone. There's definitely a stigma associated with taking PrEP, as well as being HIV positive. So that's just something to think about. However, it does show you, if they take multiple medications, it shows you what the pill looks like, so they don't get it confused with other medications they might be taking. And so for that reason, I guess it's nice. In summary, there's a lot of barriers to PrEP. Cost and adherence are two of those barriers. I hope that today you feel a little bit more comfortable with navigating the cost aspect at least. And I think that's all. What questions do you all have for me? Anything? Yeah. The question is, through the 550 clinic, how many people do we have on PrEP? Ballpark it. Not many. Less than 10, I would say. The reason for that, and there's been a discussion multiple times at the 550 clinic about how do we want to best handle PrEP. For right now, what we do is when we have a patient who's identified as needing PrEP, their partner's positive, they typically send those patients to pharmacy. So Danny's one of the pharmacists there, as well as me and one other pharmacist, Mary Bishop. We do counseling because relative to the physicians, I guess we have more time and we don't bill for our services quite yet. So we're less cost to the patient. So we do counseling with them in terms of, whether this is a good option for them and help them with any medication costs, any questions that they have. And then our job really is almost care coordination, making sure that they get referred to a provider who can do it. Since most of our physicians in the clinic receive their money they're paid through the Ryan White grant funding, they are not covered necessarily to treat patients who don't have HIV. Their funding is coming from patients who, they're paid to care for patients with HIV. So that's where there's a little bit of a hang up, I guess. We've talked about the best ways to go around that because it certainly kind of stinks to have to refer out when we are all knowledgeable enough to do it. So I don't know. As of right now, I'd say there's a couple providers who do it, but not many. For the most part, we're referring, just providing education. Other questions? All right, thank you guys so much.